Hello everyone. Today we will study about acute rheumatic fever and rheumatic heart disease. It is an inflammatory, immune mediated, non communicable, non suppurative consequence of pharyngitis due to group A beta hemolytic streptococcus. So it is a immune mediated and non communicable condition which results as an infection of group A beta hemolytic streptococci. It causes inflammation, especially of heart, blood vessels, and joints. After group A beta hemolytic streptococcal infection, it takes about 1 to 5 weeks to develop rheumatic fever. Now we will see the etiology. First is agent. We have seen group A beta hemolytic streptococci pharyngeal infection that leads to upper respiratory tract infection, that is tonsillitis and pharyngitis. Now, who is the host? It first attacks typically occurs between 5 to 15 years in both sexes. Means child are more prone to rheumatic fever. An environment, crowded living condition and persistent streptococcal strain. Means the people who are living in crowded conditions are more prone to streptococci infection, and that leads to rheumatic fever. Now we will see the पैथोजेनेसिस ऑफ रूमेटिक फीवर. तो यहाँ पे ह्यूमरल एंड सेल मीडिएटेड इम्यूनिटी दोनों इन्वॉल्व होती है. सबसे पहले स्ट्रेप्टोकोकाई का इन्फेक्शन होता है, दैट इज फेरेंजाइटिस और लेरिंजाइटिस. उसके बाद हमारा ह्यूमरल इम्यून रिस्पॉन्स ट्रिगर होता है और इन्वॉल्व करता है एंडोथीलियल इन्फ्लेमेशन को. एज अ रिजल्ट CD4 सेल्स एंड टी हेल्पर सेल्स इन्फिल्ट्रेट करते हैं और मूव करते हैं हार्ट वॉल्व्स की तरफ. तो इसमें होता क्या है, रूमेटिक फीवर में जो स्ट्रेप्टोकोकाई हमारे बॉडी में जाके इन्फेक्शन के बाद एंटीजन प्रोड्यूस करता है. तो नॉर्मली हमारे बॉडी का जो इम्यून रिस्पॉन्स होता है वो उसके अगेंस्ट एंटीबॉडी प्रोड्यूस करता है. बट यहाँ प्रॉब्लम ये होती है कि जो एंटीजन है स्ट्रेप्टोकोकाई के वो मिमिक करते हैं हमारे बॉडी के एंटीजन से. तो हमारा जो एंटीबॉडी रिलीज होता है बॉडी से वो कंफ्यूज हो जाता है कि अटैक किसको करना है. तो वो डिफ्रेंशिएट नहीं कर पाता है कि बॉडी का सेल कौन सा है और स्ट्रेप्टोकोकाई के सेल कौन से हैं. तो वो दोनों पे अटैक करता है. तो उसी की वजह से इन्फ्लेमेटरी साइटोकाइंस रिलीज होते हैं, दैट इज टिश्यू नेक्रोटाइजिंग फैक्टर अल्फा एंड इंटरफेरॉन गामा. और इसमें क्या होता है, जो हमारे बॉडी से एंटीबॉडी रिलीज होता है वो क्रॉस रिएक्ट करने लगता है हमारे बॉडी के सेल्फ एंटीजन से. जैसे कार्डिक मायोसिन हो गए, तो वो आके हमारे हार्ट और जॉइंट्स को अफेक्ट करते हैं. एज अ रिजल्ट पहले रूमेटिक फीवर होता है एंड फिर रूमेटिक हार्ट डिसीज. उसमें मॉलिक्यूलर मिमिक्री के लिए प्रोटीन इन्वॉल्व होता है, वो होता है क्लास 1M प्रोटीन. एंड द रिएक्शन which is present in this pathogenesis is type 2 hypersensitivity reaction. Now we will see the clinical features of rheumatic fever. So first is carditis. All the layers of heart are involved in this, so it is known as pancarditis. It is most serious complication. It occurs in 40 to 50% of the cases. Features of carditis develop early within 3 weeks of the onset of infection. Vasculitis is always seen in patient with carditis. Now, the important point is the most common valve involved in rheumatic fever is mitral valve or bicuspid valve, which is present on the left side between left atrium and left ventricle. And the second most important valve involved is aortic valve. Here you can see in the diagram that mitral valve and aortic valve are involved. In early stages, first it starts with regurgitation, and when it further progresses, it leads to stenosis. Rheumatic fever involves 3 layers of heart. So, first layer involves is pericarditis. The symptoms are chest pain, pericardial friction rub, pleural effusion. Now we will see the pathological manifestation. Bread and butter pericarditis, also known as serofibrinous pericarditis. Second is Escoff bodies, that is pathognomic of rheumatic fever. Here in the diagram, you can see the bread and butter appearance of the pericarditis. This one. So this is the bread and butter appearance of pericarditis. Now the second layer, that is myocarditis. The symptoms are tachycardia, drop beats, S3, S4, sound will be heard, and arrhythmias. And in pathological manifestation, we will see Escoff bodies. Now this diagram shows the Escoff body. Escoff bodies have cells that are known as anti-Schau cells. Shape of the nuclei present in these bodies are caterpillar-like or owl-like. Owl eye-like. Nuclei are present in Escoff bodies. Now endocarditis. It shows apical systolic murmur, apical mid-diastolic murmur, and aortic regurgitation. Two parts. First is valvular endocarditis and second is mural endocarditis. In valvular endocarditis, vegetations are along the lines of closure. Escoff bodies consist of anti-Schau cells and the nuclei present are caterpillar shaped. This is important. This cell important and the nuclei present in Escoff body is important. In mural endocarditis, Escoff body and the characteristic is McCollum's patch. That is map-like area present in posterior wall of the left atrium. Here we can see in the diagram that in first diagram this yellow color is the McCollum's patch, and in the second diagram also you can see a yellow patch present here in the posterior wall of left atrium. Now second comes the polyarthritis. It occurs in 75% of the cases and it is the most common manifestation of rheumatic fever. It involves large joints like hips, knees, joints of hand, feet, sternoclavicular and temporomandibular joint. Inflamed joints are characteristically warm, red, swollen, and shifting type of pain is present. Migratory involvement of pain is the characteristic of polyarthritis. As pain and swelling subsides in one joint, other tends to involve. मतलब इसमें एक बार पे एक जॉइंट इन्वॉल्व होगा, फिर जब वो उसका पेन और स्वेलिंग कम हो जाएगी तो दूसरा जॉइंट इफेक्ट होगा. एंड इट डज नॉट कॉज परमानेंट डैमेज टू द जॉइंट्स. इन्फ्लेमेशन इन अ पार्टिकुलर जॉइंट यूजुअली रिजॉल्व्स इन 2 वीक्स. मतलब जो सिम्टम्स होंगे जॉइंट्स के वो 2 वीक्स में अपने आप ठीक हो जाएंगे और फिर दूसरे जॉइंट को इफेक्ट करेंगे. नाउ द सबक्यूटेनियस नोड्यूल्स. These are small, pea-sized, painless nodules present over the bony prominence, found over the extensor surface of the joints. This is a delayed manifestations occurs 2 to 3 weeks after onset of disease. It persists for 1 to 2 weeks. Now here in the diagram you can see the subcutaneous nodules present on the extensor surface of the joints. And the most common sites are elbow, margin of patella and scalp. Fourth comes erythema marginatum. These are rare but characteristic of rheumatic fever. These are erythematous pink rashes with a clear center and round margins. It is a macular eruption with round borders and most commonly seen on trunk. proximal of extremities, but this is main point, that this is never found on face. Here in the diagram you can see erythema marginatum. Now Sydenham chorea, also known as Saint Vitus dance or chorea minor. This is characterized by emotional lability, uncoordinated movement, and muscular weakness. Psychotic features are present with obsession. Appears after a long latent period up to 6 months. It usually occurs in females. Now we will see the typical signs that is seen in Sydenham chorea. First is milkmaid grip, that is alternate squeezing and gripping when holding someone's hand. Second is spooning of extended hand. Third is pronator sign. Fourth is jack in the box sign. That means the patient is unable to keep the tongue in protruded state and tongue moves in and out. And the fifth is bag of worm appearance, which can be mostly seen on the tongue. Now the factors which induce, first is pregnancy and second is oral contraceptives. Sixth symptom is fever. It is almost always present. The fever is irregular but well marked, that is from 101 to 103 Fahrenheit. Hyperpyrexia is associated with delirium, convulsion, and coma. Most common valvular lesion in rheumatic fever is mitral valve, that results in mitral regurgitation. Now we will see the diagnostic criteria of rheumatic fever. First is major criteria, that we can learn with the mnemonic zones. It is also known as zones criteria. J stands for joint pain. O stands for carditis. N stands for nodules, that is subcutaneous. E stands for erythema marginatum. S stands for Sydenham chorea. So these 5 are the major criteria of rheumatic fever. Now we will see the minor criteria. It has the mnemonic cafe pal. C stands for increase C-reactive protein, that is more than 3 mg per dl. A stands for arthralgia. F stands for fever, that is more than 38.5 degrees Celsius. E stands for ESR, more than 60 millimeter per hour. P stands for prolonged PR interval. A stands for anamnesis suggesting of rheumatism. And L stands for leukocytosis. But this is not included according to 1992 revised zones criteria. Now for diagnostic, evidence of group A streptococcal infection should be present with 2 major criteria or 1 major, 2 minor criteria. If Sydenham chorea is present, it does not require gas evidence. Now we will see the investigation. First is isolation of group A streptococci, isolated by throat culture or rapid antigen detection. Second is streptococci antibody test. This test confirms the recent streptococcus infection. Anti-streptolysin O positive in 85% of rheumatic fever patients. And anti-streptozyme. Third is acute phase reactants. It confirms the inflammatory process that includes CRP and ESR. Fourth is chest radiography, which shows cardiomegaly and pulmonary congestion. And the last is electrocardiography, that shows myocardial dysfunction and valvular dysfunction. That's all for the rheumatic fever or rheumatic heart disease. Thank you. Please like, share and subscribe the channel.